we will go answer those questions. So without any further ado, I want to introduce Maggie Savo. We are excited to have her present, Dr. Maggie Savo. She's going to be presenting on avoiding visualization misuse and disillusion by understanding your stakeholders. And she is the Healthcare Improvement Analytics Director for the Baylor Stockton White Quality Alliance. And, you know, her role is to build machine learning models and implement value-based analytics, and so that they can achieve higher quality. And she holds a PhD in biomedical engineering from the University of Texas Health Science Center in San Antonio. So without any further ado, Maggie, I will turn it over to you.
Good morning. Thank you. So, yep, as Teresa said, talking through project translation and how our analytics team at the QA has been able to successfully partner to get some really wonderful results and savings back to the system. So, next slide. I think most of you have heard this already, but Baylor Scott and White Health is one of the largest non-for-profit healthcare systems in Texas, one of the largest in the United States. The Quality Alliance is a subset of our overall physician population, and then we have key partners in markets to address service needs. This network takes on accountability for the cost and quality of our members' outcomes. We've been able to achieve and maintain success being amongst the top 10 ACOs with Medicare shared savings for 2 years in a row per CMS. The important part on this slide, the numbers. We're big when you work with data. This many members, this many facilities, we have a lot of data coming in. Next slide. My goal today is to share with you tips and tools that are used at the Quality Alliance to support our leaders and physicians, and how we keep our analytics team working efficiently. We'll review the importance of asking questions, how to translate requests into actionable insights, how to make data digestible, and how we manage capacity and prioritization to stay efficient. Next slide. Analytics doesn't always get a seat at the table. We're often late to the party, which can put our team at a disadvantage of not hearing the full story or ask. We work hard with our team to develop their comfort with asking questions, even of our executives. In a healthcare system as big as ours, with regions, hospitals, service lines, they all have their own nuances. As we hire team members from other industries or fresh out of school, learning our system is hard and has a steep curve. The faster our team can get comfortable asking questions, the quicker their analysis becomes value add. The ability to both ask and answer questions is critical to learn. Going back to Socrates and his method to draw out beliefs and assumptions about a topic. If you're a TED fan, Dan Rothenstein's talk on the Socratic method is worth the watch. Spoiler alert though, it identifies that strategic questioning is of the utmost importance. So how do you teach your team to ask strategic questions? Help them define a good question. All questions should have a purpose. Don't disguise your opinion as a question. Don't you think it should? Or have you considered? Leave those off the table. Keep your questions clear. Keep them brief. Keep them simple. But keep them thought-provoking. You don't want yes or no answers. You want questions that define, clarify, and focus the discussion. And always ask, what else? This is a great technique actually picked up from a physician training course on communication. Give this a try in your real life sometime. If you're finishing your grocery list, ask your family, what else? There will always be something. If you're reviewing action items for a weekly one-on-one with one of your team members, ask them what else. You will always get more. Next slide. Here's a real example. So we received a request to create a Power BI that shows what % of our facility volume is a BSWQA member. So for a system with 50 hospitals and 160 outpatient clinics, we thought this would be a great exercise for a new hire. Nothing like throwing them in the fire. So meeting 1, questions kind of went as you see it on the screen, pretty simple. If you'll, next. Meeting 2 started out with our analyst looking like this. Next. One more. There we go. What she discovered is that our hospitals were on 2 EHRs. So finding one data source as the source of truth was nearly impossible. As we continued to discuss visit types, data available, we kept asking the analyst what else. This challenged her beliefs in what she could be able to identify and why she was getting stuck. Her questions became clearer and simpler, which helped to shape her approach. We finally got to the point that visit types were defined across facilities and were able to group data and create a visual that was really easy to understand. Keep asking, what else? Next. Getting to the heart of the matter, communication. Executives, clinicians, analysts, they all speak different languages. Some of the words will overlap, but the asks are all stated, interpreted, and delivered differently. Keep asking why or what else. Eventually, a root cause will be identified. Get comfortable. Help your team get comfortable with asking questions until your description matches that of the requester. Find a process that works for you and your team to repeat back the description. What I heard you say, what? Let me make sure I understood what you're asking. Putting it in your own words and having that conversation dialogue back will make both people have more confidence and the outcome meet the need sooner. Also, find a way for your team to share both soft skills and technical tips. When working with Maggie, she assumes XYZ, or patient demographics are most similar at ABC facility, or use this flag, use this data set, got to join on this column. Keep those items in a readily accessible location. Azure DevOps, Wiki, we use those both. We keep them live, breathing, and they've worked really well for our team. And then find a place on Teams, SharePoint, and integrate all of those tips and tricks into your onboarding exercises. And don't think of them really as onboarding, but think of them as a document to help support or refresh, or really that dictionary that people can go use and find the answers. This will help your team mature. It will also help your new hires get up to speed faster. Next. Our executives and business partners often invite our analysts to meetings and request actionable insights. Great. What are you looking for? What capacity do you have? Blank stares. The request then changes to, you tell us what we need to do to improve performance, and we'll tell you what improvement work we're going to do. Ooh. So we use this 4-step process, which aligns really nicely with Plan, Do, Check, Act. So as we're in this lean culture, planning for us is identifying the data that we have available. Identify the data elements that are helpful to set your scope and Define realistic expectations. Create a good problem, identify your objectives, and be really honest. Creating a new interface isn't going to happen in a normal project timeline. So be clear up front about what can or cannot be delivered. Create simple visuals. Keep them simple because they're easily understood. While a fancy visual feels cool, your audience isn't going to have time to figure out your conclusions. And they're certainly not going to remember them if you're not sitting at the table later. And remember, iterative process. Just like the analysis and visuals we perform, start simple. Then as you develop mature partnerships, you can come back and you can create more robust visuals and to address more complex questions. Leverage your partnerships you're building and the trust that you're creating. Check. Identify that your insights are available from the visualization. How many patients do you need to be adherent to hit a target? What patients are likely to pick up the phone? Think about what makes good insights. Keep those insights aligned with the goal. Display the results clearly. And then identify what insights are meaningful to the team taking action. Don't give nurses insights related to cost savings and finance. They can't do anything with them. Keep the insights relevant to the team doing the work. Finally, act. Recommend actions based on the insights. Explain your recommended actions as you walk through the visual. Explain how the visual shows and how they can use that in developing their improvement initiative. Next slide. Good stories depend on what you're looking for. Numbers, tables, data, they can scare even our best leaders. The challenge we see on a daily basis is enabling our analysts to tell a story using words their audience can relate to. In digestible chunks, the audience can feel confident retelling and sharing. Truth is, analysts and developers that enjoy data, they're introverts, they're socially awkward. So you have to enable them with a way to connect with a leader. To get that leader hooked on the data story, all while empowering our socially awkward yet amazingly intelligent team, is the key to success. So the steps on this slide are an ever-evolving process that is continually challenged and improved upon, most of which I've already spoke to, but just remember, characters and story and actions are the key takeaways that your leaders are looking for. Next. So readmissions. Within our system, it has at least a half a dozen metrics, task force, but it's always inconsistent and poorly defined. Even though we really have some of the smartest analysts on that measure, if they couldn't tell a story to get our leader buy-in. So this is a real life bullet point taken from a slide. And if you'll hit next, this sums it up. Within the first 5 words, like you've already stopped paying attention, you're not reading it, it's just not helpful. So our leaders were sitting here trying to recall what factors were agreed upon, what is the O to E ratio, and get what value are they supposed to get. Break that novel into short stories, into digestible chunks. Next slide. Don't let poor communication result in good insights getting lost as noise. Develop your characters. If I have to read more than 10 words in a row on a slide, pretty much guaranteed I'm going to tune out. And most likely, I'm going to ask a repetitive question because I don't want to read your words. So leverage simple visuals. This is another bar chart. And if you hit next, we then identify the low-hanging fruit for you. We're going to tie those character traits into that circle, back into what our characters are. We're going to recommend specific actions to that group of actionable patients. Our care management team is our largest headcount within the Quality Alliance. We spend a lot of time integrating their patient outreach into quality improvement initiatives by simply breaking down the results into bite-sized chunks. Being specific about the characters or the people or the members or the providers that they can action helps bring a recommendation to drive discussion and improvement. Next slide. So when technical folks think about throughput, it's often around data transfer bits per second. But what I want you to think about is capacity, prioritization, and effectiveness. Do you know your team's capacity? Use some type of time tracking. Start simple so you can have poorly defined buckets where your team can track the hours they use. As you begin to evaluate how many hours are spent in meetings, you'll cry, and you'll find a way to eliminate waste. You'll want to identify what business partners or requests are consuming the most hours. You'll start to track different fields, requesters, databases used. It will help you put an objective number to the total hours until your team cries uncle. Use that to support your request for more FTEs, to scope out future requests, Our team functions right around 90%, which took years before my leadership to eliminate too many meetings, establish processes and best practices, structure a database that doesn't require a year-long learning curve. This 90% is high compared to other teams, but by nature of an analyst personality, there isn't a whole bunch of chit-chat going on either. Prioritization. All requests or projects should have a business sponsor. Ideally, this is someone at the VP level or above with visibility to a broader scope or system or business unit. This will help keep your work relevant and aligned. We've all had work with too many cooks in the kitchen. Keep your prioritization team as small as possible. This will help you get a decision and have accountability. Review and prioritize all asks, at least on a monthly basis. More frequent, the better. This ensures that any new work added continues to align with other initiatives and analysis being completed. It's not uncommon for the analyst who supports our quality work to be working on something that will be used by a network analyst in the next couple of months. So thinking about how all of that interrelates and the prioritization between teams is important. So this visual over on the right, if you do quick math, totals 100. No team functions at 100%. So really my recommendation is to create the buckets like this and use a total hours of 85 to 90. Using this type of structure, you can see that there's a balance between keeping clean data infrastructure, providing insights, and operational works just to keep the lights on. This team requests new work about quarterly, depending on requests received, scope of work. So we'll prioritize that work for 1 or 2 quarters at a time. And absolutely, fully transparent, there have been times when an urgent request comes in, we stop all of our work, we provide a list, and we ask work to be reprioritized. We want to make sure that our teams are always working in alignment with our leaders and system priorities and goals. This is a key engagement driver for our team. So take a breath, start simple, do some type of capacity time tracking, prioritize work, and just don't dive in head first. Take it in chunks. Next slide. So where are we today? We are leveraging machine learning like we never have before. We truly have some of the smartest, cutting edge folks in analytics, and it is a wonderful team to work with. They're supportive, and we have a high level of engagement. And so what you're going to see presented just after mine is how we're able to use that predictive modeling, our risk stratification, to really partner with our teams to get more benefit for our patients, which at the end of the day is what everyone in healthcare is trying to do. So we've developed new risk models. We are supporting our care management teams and our clinical excellence teams in ways that we never have before. We're partnering across multiple analytics teams, data platforms, data types, to really provide integrated data to improve care. And what the two bullets that have down there at the bottom, those have really been key to our successful transformation as an ACO, as a team of analysts, is to really create analysts that are your subject matter experts. And then keep advancing the complexity of insights that you bring, that your team brings, as frequently as you can. Because the more complex your insights get, the better and bigger your improvement initiatives become, and the more confident your partners are in their ability to read, interpret, and apply data. Next slide. That's me. That's how to get a hold of me. So appreciate and open to any follow-up emails, or I think we have a couple of minutes for questions, Teresa. Teresa?
I thought I unmuted myself. I apologize. Thank you for saying Teresa. Okay, now I'm unmuted completely. So yes, if you have any questions at this time, you can post them in the question. I don't have any at the moment. So I'm getting comments though, Maggie, about excellent presentation.
Thank you. I appreciate it, and I'm sure that everyone's going to enjoy Ray and Carmen up next.
So, I do have one comment here. It says, from one of our attendees says, I was a bit concerned about the don't disguise an opinion as a question. It says it does not have to be, don't you think that, but can it be, what do you think of?
So that's fair. What we see sometimes in our culture is that people get very stuck looking at data or initiatives one way. And sometimes it can be hard to come in with a fresh perspective or to welcome a challenged thought. And so it's really that comment around be open to what you hear, and don't let folks bully or push their own personal agenda through in some of those early kind of brainstorming development meetings.
Okay, great. And of course, I'm being asked if this was recorded, and yes, we have recorded the session, and lots of compliments to you, Maggie. All right, then, if we don't have any more questions, we're going to proceed to our next presenters. which are Carmen Davis, as Maggie was talking about, and Raymond Pacheco from, again, the Baylor Scott and White Quality Alliance. And they're going to talk about how they've made some data actionable. It's called Utilization of High Need, High Cost Risk Stratification to Support Personalized Care Plans for Individual Needs. Carmen is the manager of the Comprehensive Care Management, and she's been a licensed social worker and practiced medical social work for over 15 years. And she's been at Baylor Scott and White since 2006. And she has comprehensive care management practice, including oncology, palliative care, inpatient ambulatory, emergency department, and population health. She also works with the Community Advocate Program and has managed a successful high-impact disrupt ED navigation program. So she has her bachelor in social work from Stephen F. Austin, yay, Texas, and a master's in science from University of Texas at Arlington. Raymond has his master's and from the University of Texas at Dallas, and he's the development manager. And his role is to lead the team that supports the analytic needs for the Comprehensive Care Management Department and identifying those insights and population needs and tracking health outcomes. So with that being said, we're going to allow them to get started. Raymond? Carmen?
Thank you so much, Teresa. Can you hear me?
Yes, I can hear you.
Great. Thank you so much. As Maggie mentioned, the Comprehensive Care Management team is one of the largest departments with the Quality Alliance. And so you can go to the next slide. I just wanted to give everyone a bit of background and overview of our team and how we work and some of the work that we do. Our team consists of RN care managers, social workers, health coordinators, community health workers, and then our pharmacists and pharmacy techs also function as a part of our team. We align and work directly with our providers. Most of the work that we do is telephonic outreach to our patients. And we focus on three main interventions: transitions of care, chronic and preventative gap closure, and proactive panel outreach. With transitions of care, we outreach patients who had an inpatient or an ED hospital visit. We contact them within 24 to 48 hours of their discharge and follow them for up to 30 days, depending on their needs. This outreach focuses on a patient's understanding of their discharge instructions, making sure they have follow-up appointments, medication reconciliation, and other readmission prevention strategies. Chronic and preventative gap closure. So once a patient is identified as having a gap, so maybe they are due for a diabetic exam or cancer screening, we coordinate with providers, schedule those appointments. Sometimes we just need to help getting the test results. And everyone on the team is responsible for addressing gaps when we come across them, but we do have a team of health coordinators that are dedicated to this work specifically. Lastly is our proactive panel outreach. And this is really how we action our high-risk population, where we measure our member engagement. Each month, high-risk patients are identified by our analytics team and placed on a panel. And then our team proactively outreaches these patients to try to get them engaged in care management. Currently, our health coordinators and community health workers will make that initial outreach to try to get a member engaged. And if they agree to participate, then they would receive at least a monthly outreach from an RN care manager or a social worker. This monthly outreach, they set goals, address disease management, a lot of patient education and care planning, med adherence, and then we address any psychosocial needs that might come up during that time. We spend a lot of work around focusing on these high-risk members through this proactive panel outreach. With all of these interventions, we rely heavily on risk stratification. It helps us to determine who on the team outreaches the patient, the depth of that intervention, and then how long we might work with the patient. It also allows us to ensure everyone on the team is practicing at the top of their licensure or they're functioning fully within their scope of practice. Historically, our RNs and social workers work with our high-risk members who tend to be more clinically complex, and then our health coordinators and community health workers will work with our low, medium-risk members who may not need as much. Next slide, please. Before we get into the details of this slide on our high needs, high cost risk model, I wanted to give you all a bit of background on our previous model and how we kind of arrived here. Our previous model really leveraged experience, spend, and chronic conditions to risk stratify and predict future spend. Being that it relied heavily on detailed claims data, it was highly accurate. But again, it focused on risk stratifying after the spend had already occurred. It didn't afford us the opportunity to really negate that spend or action a patient likely when they needed us the most. It was also a one-size-fits-all across all of our contracts. So Medicare and commercial alike, we would take the top 5% of each contract and just put those into a high-risk bucket. But of course, a Medicare high-risk patient tends to look a lot different than a younger, healthier, commercial high-risk patient that just happened to fall into that top 5%. We would also get scenarios where a patient might be considered high risk and fall into that category due to a single acute episode, maybe a one and done surgery, but they didn't really need that ongoing support. And we would hear all the time from our team that they would outreach these members who really didn't seem to need care management despite them being considered high risk. Which brings us to where we are today with this high need, high cost risk stratification model. We wanted to improve upon our methodology and make our risk model more actionable. In our research, we found a lot from the National Academy of Medicine project around effective care for high needs patients. So not just high cost, but also high need. Understanding that, high needs patients are diverse and other factors go into them being high need in addition to the cost. So that could be clinical complexity, functional factors, behavioral determinants, social determinants, medical determinants, and then, of course, the higher healthcare costs. This high need, high cost model factors in all of these components so that we get a more holistic view of a patient's risk profile, and then we can forecast anticipated spend. It allows us to segment the population so that we can group them into cohorts based on the type of risk that they present. And with the knowledge of these cohorts, we're then able to develop clinical programs. Our team is also able to incorporate these factors and this risk profile into their outreach and how we engage our patients, which was huge because previously it could sometimes take 2 to 3 calls to really get a patient engaged and ready to set goals and start working with their care manager. We were spending a lot of time trying to help patients understand how we can assist them and understand how their care manager could help them. And this model just gave us a better place to start because we had some insight into their clinical complexity and functional factors, etc. We know that members, their engagement increases when their treatment plan is more specific to their needs. And this model really helps us call out those specific needs of the member. Next slide. So the different cohorts that the model will identify here are children with complex needs, non-elderly disabled, major complex chronic conditions, multiple chronic conditions, frail elderly, and advancing illness. And if you don't fall into any of these, you would be considered relatively healthy. And a patient could fall into multiple of the cohorts. To give you an example of how we would utilize the model to develop a clinical program, take, for example, the frail elderly cohort. A frail elderly clinical program would provide some guidelines about what type of care coordination this patient cohort needs as a best practice, and not just for comprehensive care management, but also for the provider and other care team members. Guidelines could include, making sure they have a monthly PCP follow-up, advanced care planning, hospice assessment, pharmacy med reviews, pharmacy education and de-prescribing, enrollment into a fall prevention program. And then we can also tie this back to some of our more strategic initiatives. For example, what does our member engagement need to look like for this specific cohort, and setting some goals around that, or what should our ED admission rate look like for this group, and setting some goals around that. And as you can imagine, the way that we action this frail elderly cohort would look quite different from how we would action a relatively healthy cohort. The behavioral determinants here: substance abuse, serious mental illness, cognitive decline, and chronic toxic stress, which includes anxiety and depression disorders. Having some visibility into these factors really allowed us to better identify which of our patients need to go to a social worker who's trained and has the background to address these areas, and also some of the social determinant factors. And the social workers are able to address those areas in a more targeted fashion. So having this information before we start working with a patient is very, very valuable. And we are working to develop these care models and clinical programs that directly target these cohorts and develop interventions specific to their needs. Next slide. And to give you an example of how we utilize this model in comparison to our previous risk model, let's look at our frail elder again. So like I mentioned before, our previous model really leveraged experience spend. So let's say this frail elder had a fall and needed to go into the hospital for traumatic hip repair. We didn't see that spend until after she had the fall, was admitted, had surgery, left rehab, and was back home 3 months later, and it ends up on a claim. We could then identify her as high risk and start to action her at that point, which a lot of times we found at that point our patients really didn't need the care management services that they would have needed 3 months ago. With our high needs, high cost model, the spend is calculated in comparison to other patients in the cohort. So the model would tell us that this high-risk frail elder is expected to spend $84,000 over the next 12 months. She would be flagged high risk at that point, and then we could go ahead and complete an assessment to see how we could help her, put her in this frail elder clinical program or a fall prevention program, and hopefully avoid that fall altogether, and therefore avoiding that spend. And that's really the advantage of this model, is that it allows us to be more proactive and to focus on cost avoidance strategies specific to the cohort. The model is also predicting potential spend better than our previous model. So when we look at this comparison of high-risk members with $150,000 of spend. With the high needs model, we're identifying it 80% of the time compared to 50% of the time from our previous model. And at this point, I'm going to go ahead and hand it over to Ray so that he can give you more insight into some of the more technical details of the model.
Awesome. Thanks, Carmen. Excuse me. And just wanted to point out that I am one of those socially awkward analysts that Maggie was referencing earlier. So just throwing that out there. Yeah, so for part of the talk, for my part of the talk, I'm going to try to address the question, like I don't feel to get this discussed nearly enough. When is it time to update your risk model? And how do you know when that risk model is worthy of replacing the prior one? So I'll talk through some of the analysis we performed along the way as we developed this model and got it ready for prime time so that we could be used by our care management program. So before we move on to the next slide, just kind of like to address this information. Yeah, let's see on that one, sorry. Just kind of like to address the information from an analytics perspective. Like as Carmen mentioned, we have moved from a highly detailed, highly accurate model to one that's more actionable. So let's take a kind of step back and talk about our prior risk model from our point of view. So our last model was very much so a black box model. What I mean by that was it was an ensemble. It used several different machine learning algorithms. We used a gradient boosting machine, random forest, neural network model. We also use roughly 200 risk factors to power each prediction. These included basic demographics, diagnosis groupers, procedures that occurred in the prior year, and pretty much any and all prior utilization. Well, yes, we did use diagnosis groupers. The model tended to focus highly on that prior utilization, as Carmen kind of alluded to, in determining that predicted output. So in any other scenario that might be useful, like if we were talking like credit scoring or any other type of predictive algorithm in that sense, this ended up being a huge hindrance when we're trying to determine who best is suited for care management. So as what was mentioned before, we've come across several scenarios where someone with multiple chronic conditions who could absolutely benefit from care management services, but just happened to be keeping their chronic conditions in check well enough that they didn't have any excessive utilization. They were identified as lower risk than someone who might just be excessively using urgent care services or something to that effect, but overall was relatively healthy. And so from our side, we'd heard this and several similar stories from our care manager for some time. We really never had a good opportunity for developing a new model that would address these concerns and other things we heard along the way. So when we came across this article from the National Academy of Medicine, it was called "The Effective Care for High Needs Patients." We felt like this is a really great opportunity to basically think outside of that black box we had built prior before. So the NAM article spoke really to trying to put these patients into higher, excuse me, higher groupers of, might have relatively similar needs. So we took that into account, and we're now using less than 50 risk factors within this model. So previously we were using what's called the clinical classification software for our diagnosis groupers. If you're familiar with that, I think there's roughly 200 of them. It's a good system. However, we felt that condensing them into these, the ones that were shown on that prior slide, was going to be more effective, both for the algorithm to be able to pick up groups that were more identical, and also for our care managers groups to kind of build those care programs around. So with this kind of became a more simplified model to some respect. So your first concern might probably be well, how much predictive power did you end up losing? So that's one of the first things we looked at when we created this new model. if you look at the graph on the right, we really didn't lose much. There's a really strong correlation between the predictions from the prior model and the predictions in this new model. So we felt pretty good, moving from the black box model to one our business partners could better understand and better create the care management programs Carmen was talking about. You can move to the next slide. So after, just kind of making sure, gut checking that we're not going to lose a ton of predictive power from model to model, we wanted to kind of validate that the layers within this high needs model made sense. So one analysis type you can use to do this is what's called a gain analysis. You can look at the features that are being, you can look at the risk factors that are being featured when trying to identify the risk of a patient. Specifically, the gain scores were determined for the medical determinants and compared against clinical utilizations and social data. So the data slice we're showing here is for all of our Quality Alliance members, but we also looked at this from a couple of different aspects, including just our Medicare population, and then just who we're calling the very high need members. So if you look at the bars on the right, they had identified those significant features that were determined by our risk model. We could, look at them within each medical determinant and see what was basically helping determine predicted spend. So, for example, some of the significant features for predicting spend for our members in the advancing illness determinants were ED utilization, creatinine values, and then also BMI. I think one of the coolest things about this type of analysis is we were able to share this with our business partners to get their feedback on whether they felt the model was making decisions that made clinical sense. So it's true we could have done this with our prior model, but I think it's a lot simpler to ask and understand what risk factors would you expect to be driving members with multiple chronic conditions or children with complex needs, than trying to show this for those several dozen CCS categories. Next slide. So this is kind of our next step and kind of trying to determine whether our risk model makes sense and moving forward with. Because we based this on a NAM article, one way we were able to test the validity of our new model was by checking the findings against what was discussed in that National Academy of Medicine literature. So to do this, we use cluster analysis technique called K-means clustering. So we evaluated the Quality Alliance population to kind of identify those homogeneous subgroups with similar data points, similar features. So you can kind of see some of the output of that's preliminary and secondary analysis here. So we had very high and high risk members that were first subgrouped into 3 clusters. That's the first preliminary analysis. Clusters 2 and 3 were similar to each other, but quite different from cluster 1. Cluster 1 members are younger. They included the non-elderly medical determinants and have a higher percentage of females, significantly more pharmacy spend, and significantly more counts of active prescriptions, and increased prevalence of behavioral and social determinants. When subgrouped into 2 clusters, which is that secondary analysis, the same significant features were identified. So cluster A was younger with higher prevalence of females, higher pharmacy spend and prescription counts, and an increasement of prevalence of behavioral and social determinants. Cluster B was reflective of both cluster 2 and 3, so older with either more advancing illness or more major complex medical conditions. We also looked at our medium and low risk members and evaluated them in the same cluster analysis approach. The clusters in the medium risk populations were most similar to cluster 1 in our high risk analysis. And for our low risk members, they were predominantly female, having lower prescription counts compared to the high and very high members in either of that cluster A or cluster 1. So when we looked at, compared this to what the NAM article defined, NAM article identified subpopulations with behavioral health conditions, younger, female, less educated, and more likely to have lower income, poor health, and be impacted by, 4 behavioral variables: substance abuse, serious mental illness, cognitive decline, and chronic toxic stress. So really, what we had identified in our cluster analysis aligned really well with the NAM results. So, we both had that younger females with high prevalence of those 4 behavioral health conditions: that substance abuse, serious mental illness, cognitive decline, and chronic toxic stress. NAM article also identified a high need subpopulation that was older, female, more likely to be publicly insured, and have fair to poor self-reported health. So looking at our entire population, the very high and high risk members are older females on Medicare with increased percentage of high financial strain. So the population partitions identified within this cluster analysis are very similar to the cohorts identified by the NAM publication, and continue to support our need for moving towards this model in our care management program. Next slide. So the last thing we're going to share today is around the programs that Carmen mentioned earlier. So our main use case for our risk model is in determining which members are most appropriate for our proactive care management program. On the analytics side, we do this by bucketing our members into those risk levels that we've talked about, so the very high, medium, and low risk, and then identifying which ones are high, very high risk, and determining which of our care managers are are best suited for tending to their care management needs. So one really cool side effect of this model is we can now look at member engagement in this program through the lenses of those medical, social, and behavioral determinant groups. By engagement, I mean whether a member is basically amicable to joining our care management program and working with those care managers on an ongoing basis. So if you look to that chart on the bottom right, it probably won't surprise you that our members with some level of isolation are the most likely to engage with our care managers. So we have those somewhat isolated, severely isolated, and moderately isolated as kind of our top 3 when we're ranking groups that are most likely to engage with our care management program. This is still kind of a work in progress, but with this perspective, we're kind of hoping to accomplish a couple of things. We would like to hyper-focus the members we assign to our care managers with those most likely to engage so that we can make the most out of our time. One thing today that happens is our care managers end up making a lot of phone calls, leaving voicemails, and just talking to patients who aren't really willing to engage in the program. So if we can kind of give them like an idea of who's more likely to engage, we'll hopefully save some of that time for them so they can really, be working at the top of their profession, actually working with those patients who are going to, want to participate in that program. And number 2, kind of better understand areas of opportunity for cohorts of member who are least likely to engage. So while we want to give the, those that are likely to engage to our care managers, maybe we need to revisit, what we can do better for those, members who definitely would, benefit from proactive care management. But right now, we're not really structuring things in a way they feel it meets their needs. So can we design better programs? Maybe telephonic outreach isn't the best for them. Maybe, something text, something digital platform, these are, some of the questions, we would like to answer going forward when working through this portion. Next slide. Yeah, and that is it. Those are our email addresses. You can reach us at either of us if you have any questions. And I mentioned that source for the, what we use for this risk model. So that's the name of the paper there, if y'all like to go and read that.
All right, great job, Carmen and Raymond. If anyone has questions, they can post them now. And great job. It's very interesting what you're doing. And we do have some questions here for you, so I'm going to go ahead and start asking. The first question is, what advice would you give to hospitals who wants to develop similar programs but not enough resources and bandwidth? Carmen, Raymond? Hello? Can you hear me?
Yeah, sorry. Can you clarify, like resources? You mean not enough, like analytics resources, or like?
I'm thinking, I don't know if they mean resources like data-wise or resources because not enough people. Like you don't have enough staff to do this. What kind of recommendations, advice would you give?
I mean, from the analytics perspective, I mean, I get not having enough resources. We have plenty of, team members in our, analytics department, and it still took us quite a bit of time to, vet through this model and, get it ready for our care management program to be used.
How long did it take you, Raymond?
Sorry, what?
How long did it take?
It was roughly a year from when we first got this article to when we were able to actually, put this out into production. Like honestly, we use this, we leverage a lot of our free tools. Everything we do is, using like public, open source software. So we utilize R a lot, for that predictive modeling, building. And, there's a ton of stuff out there in Python and R that's open source. So if like financials is kind of the issue, like there's a ton of sources out there that are completely free. There's a ton of like things out there for like learning how to build these models.
Well, isn't also from like just trying to organize time, is Trello one of those tools that I think Maggie talked about that you can use to help be more organized?
Absolutely.
It's free.
Exactly. Trello is a free source. So trying to organize your time, like you want to be able to make, if this is something that's important, you're going to have to figure out how to prioritize this with the, your senior leadership. And yeah, just kind of get them to understand, what other things y'all are working on and where this can fit in so that y'all can kind of make this this work.
Okay. Our next question says, can you use this to build a visual representation that is a quick read for providers so they see the risk level for the patient right away, like color-coded or a grade or score?
Yes, absolutely. And we've definitely done that. So, we have integrated these risk models into our EHR platform. So on that, when they go into a patient's chart, they can see, what risk level we've deemed them, and also that, risk score that goes along with it. Kind of other BI tools we've done with this product is kind of like done some Power BIs where we're just kind of showing like high level where there are like higher concentrations of high risk members, by region, by clinic, etc. And also just kind of drilling down into those high level medical, social, behavioral determinants.
Okay, and then our next question is, have you looked at race and ethnicity and the time needed for engagement?
That is not something we've looked at yet. It is definitely something that's been talked about, but not something we've explored just yet.
All right. Well, I think that's all the questions for now. Great job. This is recorded and the slides and the recording will be available at the end of the conference. We appreciate your time, Ray and Carmen, for coming and presenting to us today. Thank you. So that being said, we're going to go on to our next speaker, our final speaker of the day, which I'm really excited. I'm just getting to know Dr. Jerry Henderson. He's the CMIO at JPS Health Network. He's Fort Worth native, so he's a Texan, and he completed medical school at the Royal College of Surgeons in Ireland, and residency at UT Medical Branch in Galveston, Texas. He was recruited to MD Anderson Cancer Center to work in a specialty unit, and he developed and implemented a clinical fellowship in oncology emergency medicine. Let's see here. Because new tools were required to support the field of oncology, he began work on software to manage those patients. And it was called Zero-G, and it ran the clinical documentation, ordering, messaging, prescription writing, all different kinds of things. He obviously has had a lot of success, and through that he was recruited to leadership to help implement Epic across organizations. And we all know many of us here in the DFW area, except for a handful, have Epic. He was recruited to Associate Chief Medical Information Officer at the Cancer Center and completed his MBA at Rice University. He moved back to Fort Worth in 2019 and began working as CMIO for JPS. And most recently, he has brought telehealth capability to JPS network and has designed new tools to screen and care for COVID-19. So we're excited to have him here today and have him present to us on healthcare innovation. Dr. Henderson, I turn it over.
Yes, hey, thanks for that wonderful introduction. Can you hear me?
Yes, I can hear
Okay, all right. It's good to be back in Fort Worth. I really missed Fort Worth for, I should say, most of my life, the time I was away. But I find this topic is extremely, I'm very passionate about this, and it's a super exciting field right now in healthcare, this area. So next. So this is just a silhouette of Japanese Zero. And this story really resonates with me because I've been in this position a lot of times. And so in World War II, the Japanese Zero it almost won the war in the South Pacific because it was just so innovative. It was so dominant of a fighter. But what most people don't know is that it's widely believed to have been copied from an American airplane. And that was the Howard Hughes H-1 design, which broke the world speed record in 1935. And so Howard Hughes, he offered to give this plane to the Army back before the war, and they rejected him several times. And so, the lesson is that just because you have an amazing solution doesn't mean that the world's going to beat your door down. You still have to convince them that it's an amazing solution. And this is a very complicated area in healthcare. And healthcare, we do traditionally, I'd say less now than previously, but we suppress some great ideas because of our culture and tradition. I just often think about my colleagues in other fields and how different that is from maybe the computer industry or energy industry even, as to how they view new ideas. But times are changing. As our patients start to book travel online and deposit checks to the bank using their mobile phone and schedule groceries to be delivered in the pandemic, patient expectations are changing, and these are our customers. And if we fail to meet those expectations, then they not only lose confidence in our systems, but also in our clinical care too, I believe. Next. So this is brings up a point. This is just a page out of Leonardo da Vinci's workbook, and it's just magical looking. As great of an inventor he was, very few of his designs ever actually made it into construction. And unfortunately, what we're left with is a lot of this artwork. Some of the inventions were built later after the material science kind of caught up to his design. But just to make a distinction, so invention is about creating something new, and invention is really about putting that concept into play, into use. And so I think that's an important point here. Invention is magnificent. If it doesn't go into production, then it can't produce any benefits. Next. So Steve Jobs, on the other hand, he was an innovator. He not only did he invent, he built, he changed our daily lives, everything around us. He didn't even ask permission. In many cases, he didn't ask for public opinion or for problems from individual users, because he felt like people could not even understand, what would be good for them. And so, there was an interesting story about how profound the iPhone is in our daily lives. I was listening to Edward Snowden talk about that. It doesn't even matter if NSA listens into your phone conversations, because they don't have to. They know more about you just by looking at what time you turn your phone on and off and who you call at what time of day. Your actions speak louder than your words actually on the call. I thought that was pretty profound, and that is really because the mobile phone has just so profoundly changed our lives. Next. Elon Musk, obviously, he's invented, built, he's changed the way we think about electric vehicles, space flight, and even Mars. Next. And so here's a list of people. What do these people have in common? Well, I was kind of shocked to find out that all of these people had actually dropped out of college. They were all college dropouts. But the real story here is they thought differently about the world around them, and they changed it. And these people probably didn't succeed because they were dropouts. They probably just had such radical ideas that they felt that their ideas weren't welcome in their institutions. Next. So the important thing is here, and this is Steve Jobs' quote that's very famous, is that it's a mindset. It's like a switch. Thinking about the world around you. If you believe you can make it better, you actually can make it better. Next. And so I keep a list. This is a list I compiled years ago, and I just keep track of it. These are the things that I sat down one day and I said, these are the things that need to change to make healthcare to bring healthcare where it needs to be. And these things, we've made quite a bit of headway on some of these items, and some of them we still have ways to go. But I always keep track of these, and this keeps me kind of grounded to where I think that healthcare needs to go in the future. Next. So we see innovation all around us. You go to the airport, if you're still flying, you go to the airport, you see signs like this. You see it on commercials, you see innovation in conferences like this one. So why is it good for companies to innovate? It's actually extremely important for business. So next slide. It has a lot to do with this strategic inflection point. And some companies get this, some businesses don't. But a lot of it is just staying in business. So companies follow this natural kind of trajectory, this parabolic curve of life and death. And at some point in time, you reach this sort of solar maximum where you have maximum number of resources and your company's doing really well, and then something changes. And this is the most difficult part, is to take that fund, and instead of continuing to do what you do, to take that money and invest it in research or innovation, to figure out how to change your processes to achieve exponential growth on a new curve rather than follow catastrophic decline. And next. And so you can see this blue triangle here. This is strategic dissonance, and the strategic dissonance is really the executive saying, no, we've always done this way before, why should we change? And the people on the front line saying, hey, this is not working. This is my perception, but next. But if you follow these successive growth curves using innovation and fueling innovation when you're actually in a high point, not when you're at the low point, because when you don't have money and your business is dying, there's really no extra funding to put into innovation or R&D. And so you follow this sort of series of curves, and this is how growth occurs over years. In Procter & Gamble, all large companies, this is how they survive. Next. So nations aren't, they're not immune to this either. And so you can see different nations, these are different curves. So you can see nation 1 with technology 1 has a totally different curve than nation 3 with the technology curve of nation 3. And why I think this is important is because if you look at the amount of capital you can inject into, let's say, technology 1 versus technology 3, you see that the output is totally different. And this is what gives us an advantage. This is what gives certain nations advantage over others, is really investment in technology and innovation. Next. And sometimes companies use this to manage the market. Intel, I don't know if you're familiar, but back in the 70s, they had a product called the DRAM, which was not a very complicated chip compared to nowadays, but it was pretty innovative at the time. And you know, as soon as they built the first chip, the Japanese would always arrive, and they would come in and they could underprice the chip makers with efficient manufacturing and low pricing. And so there was really no way that Intel could compete with those tactics. They couldn't compete on price. And so what they did is they used innovation to build a new series of superior products. And they got so good at this that they released the products on cycles. So they knew that high price would be sustained early in the cycle for a new product, and then they would invest in R&D for the next generation as competitors offer substitute products, and then the market price would very, very predictably decrease. And so they really created new markets for new chipsets every 2 years. And those of you who are familiar with Moore's Law, Moore was actually a co-founder of Intel. And so Moore's Law may not have been as predictive as it was actually a business strategy. So I just thought that story was kind of very interesting. Next. So innovation not only helps you kind of solve problems, it also helps differentiate yourself from competitors. And so there's 2 basic strategies. Your strategic positioning, which is basically you're saying I have a superior product, and I'm gonna request a superior price, and operational effectiveness, where you're saying, hey, we have a commodity here, and we're going to just try to compete on this operational effectiveness. And so you can, if you start to think about hospitals, even in the North Texas area, you can think of ones that, claim that, hey, we're different because we have better, smarter doctors, we have better resources, we have better facilities and technology. And then you have others that say, hey, we provide good care at a reasonable cost, and we're going to be, convenient. And so 2 different strategies, even in healthcare. As Michael Porter states, operational efficiency is easy to copy, but differentiation is really much harder to copy. And it really commands a higher price and prevents copycats. And that's why it's so valuable. Next. And so there's different kinds of innovation. Most of us kind of run, I say in healthcare, almost all innovation is this incremental innovation, which is things like, maybe we have an Uber ride, Lyft, or ride share, or something for patients that come to the hospital, don't have transportation. And then a radical innovation might be that, maybe it's telehealth. Maybe all of our visits we convert to telehealth now, and it's a game changer because it's very convenient for patients. It totally changes our operations, reduces costs. It's total game changer. But there is a cost to radical innovation, and that is not only cost of resources, but it's also change management of staff and customers. Thinking about when we went live with our telehealth back in March here at JPS, it was a huge change for everyone. It was not a huge financial change, but the change management was tremendous, not only for our providers, but also for our patients as well. Next. So everybody tries to sort of categorize innovation in a bunch of different ways. This is kind of how I boil it down. I see, well, I put at the top my favorite one, which is arbitrage of ideas. That is basically taking an idea from another market. So looking outside your market for fresh ideas. I remember when in the ED we had patients that were waiting, and we borrowed from the restaurant business those little, and you guys probably had them too, but those little flasher beeper things. So we had a stack of those, and you take one of those, you could go elsewhere, and when we were ready to come back, then that thing would beep you. That's that is an example of arbitrage of ideas. Collaboration, it's kind of similarly like an arbitrage. It's you take two different ideas from two different areas and you meld them together, but it could be from the same industry. And then combining existing ideas together that haven't been combined in the past. Thinking about things like, I wrote a few examples down here. Printing press is a combination of the wine press and the coin punch. And then, in Houston, we had this thing called cupcake ATMs, where you could go after hours and get a cupcake out of an ATM. So there's a lot of different ways you can combine things that you would think are completely different. Architectural innovation is really just rearranging the components together in a different way, in a more effective way. And this would be kind of like arranging components on a chip, arranging staff in a clinic. It's usually in manufacturing and operations. And then occasionally you get chance discovery, which a lot like a DNA mutation is very rare and rarely results in favorable outcome. Next. So if I had to go through some things that are really blueprints for successful innovation in healthcare, I'd say that the most important thing is you have to have leadership buy-in. I've been in lots of situations where we had a really great idea, where we're trying to solve a problem, and leadership we just couldn't get good leadership buy-in, or they were leadership might have been distracted by another problem, and this is frequently the cause. I'd say on the team, the most specific person you need buy-in from is the COO, or whoever drives your operations in the organization. That is the most, that, and may not be the COO. It could be a leader that is organizational leader that may not have a title of COO, but they may be the organizational leader in operations. Organizational culture is tremendously important. So you got to consider where you are. Here at JPS, if I told our CEO that I had a new way to count white blood cells on an analyzer, I'd probably get escorted out because that's just not what we do here. But at Stanford, I'd probably get escorted to the technology commercialization office, and they'd probably want to make money off of it. And so that's just sort of the cultural things that I'm talking about. I will say our organizational culture here is very favorable here at JPS to innovation, and you see innovation flourish in areas you wouldn't normally see, and a lot of that is because of the culture that it is encouraged to own whatever process you run, and that's how we push out innovation. Obviously, investment's important. You have to have not only money, as we were talking about a little bit earlier. I know that Ray was, the question was about, what if you don't have, money or resources? Because there are a lot of resources you need. You need space, you need time from clinicians. If you're borrowing their time, they, at some point expected some kind of return. This picture here is the BRC, which is the Bioscience Research Collaborative. Rice built this. It was $300 million, and they built it only so that they could draw in collaboration from the Texas Medical Center to Rice. And you can see Texas Medical Center is in the background there, and that collaboration was extremely important to them to draw that in. Empathy, I always encourage empathy. We kind of use the term deep empathy. Empathy is like empathy from a distance. Deep empathy is really you getting out on the floor and talking to people and seeing them work in their normal circumstances. Roaming the floor is one of my favorite things to do and talk to people. If you wear a lab coat, or you get treated differently than if you wear a coat and tie, than if you just wear a shirt. I like to just kind of go incognito. You get better answers, or better questions, I should say. A dedicated innovation team, a lot of people pursue this, and I will say that it's not really necessary, although the benefit is that it really, you have a ready-made team, and you don't have to recreate it every time you have a new problem. So it's really nice just to be able to toss things in there, because this team usually already gets it, and you don't have to go through all the exercises that you do initially in other places. Next. So some of the blocks to innovation, we all know this, the naysayers. I believe that naysayers are a necessary ingredient to this mix. Just because you don't want to have too many people that are positive, you want to also inject a little bit of criticism in there as well, but there's a balance. Trust is spectacularly important. I think we way underemphasize this. If you're competing with your colleagues and you don't have their trust, you know they're going to throw you into the bus when you try to, when you fail, then you're really not going to go out on that limb and try something new. You're going to really stick to what's proven. And many times, you know, there's that what's in it for me mindset. I know you guys have heard the story about New England Patriots. They recruit people that aren't necessarily the best players, but they're players that are selfless. That goes for this too. You really have to have people that are in it for the team and not for themselves. Hierarchy. I mean, I've worked in tons of hierarchy organizations. This is typical org chart stuff, but I will say that there is inherent in that organizational chart some competition, and with competition, there is a little bit of trust issues. Obviously, this is dependent on personnel and how much competition is in an organization. In general, matrix organizations tend to collaborate and tend to innovate a little bit better, but you know, you kind of you can't change this. It's not something you can change. And obviously, leaders with a fixed mindset, this is the way we always done it. Next. And you can just kind of see that's the matrix type of organization, which is really uncommon in healthcare. Next. So dream team. So, you know, sometimes companies, I've read about this, I've never seen it before, but companies pay engineers to daydream. So they find their staff that are the most capable as far as developing new products, and they actually pay for them just to just daydream and tinker. 3M has been known for their 15% program, where they give 15% of their time to do this kind of stuff, and they say that that's where they got Post-it notes and that blue painter's tape. Google also, you know, encourages this, and this is where they got the idea for Gmail and Google Earth. I don't know. I can't really see us doing this in healthcare, but maybe someday, right? New slide. Next. So the innovation team, this is kind of where it gets exciting. You can see this is a typical kind of innovation team. As I said before, it's not necessary, but if you have the ability to create one of these, it's pretty magical. You obviously have to have buy-in from operations. So that means that this can't be under the radar. This has to be above the radar, which means it's going to get a lot of attention, and it makes it a little bit more difficult to do, but you have to have that buy-in. Otherwise, the products will never get launched, and you won't have anyone to run with them. Co-creation is kind of the theme here. You really want to co-create amongst team members and not have one leader that you feel like is getting all the credit for all the work that's been done. You want to make sure that people are mentally invested. You know, people that are mentally invested, or you get people mentally invested by asking them questions, asking their opinion. I'll do this at meetings many times. You'll get people that are really, really quiet, or they're not outspoken. And, you know, you have to really call them out and ask their opinion by name. What do you think about this? What do you think about this? And, you I was reading there, even the ancient Romans wrote about buy-in in a lot of the things that they had done. So, I mean, this has been known for millennia. And next. Yeah, and I think this is another thing too. When you start introducing doctors into this team, there is always a lot of reverence and a lot of, I guess you could say there's just, a lot of respect. But the doctors should not be gods on this team. The doctors should be team members, and everyone is equal. This is not to be. This is a team, and it's not a. I guess it's not going to be led by one individual. Although it usually benefits from a facilitator. That facilitator is not really seen as a leader. So the other thing is make sure that these team members are stretched. Make sure this team is stretched. So you need to give them stretch goals. You need to really challenge them. And if they're not coming up with very creative solutions, you really have to push them to that. It's really helpful to establish a framework for activities. Scrum, rapid development cycle sort of methodology works really well. Here we have team meetings like once or twice a day, short meetings, standing meetings, but otherwise it turns into a really, really long project. So it helps make everyone accountable and helps everyone level set when you have these rapid development cycles. And it's good that you have a diversified team. I've always found that frontline staff are very, very useful here. It can be useful as well to have financial staff because they can write financial reports, and then business staff because they can write the executive summary. And so it helps to have that expertise on the team as well. Not to mention the finance staff also know where all the numbers come from. So it's very important. Team size, research has shown that 7 is kind of the magic number, at least any more than 7, and you diminish your decision-making capacity. The research study says for every member you add after 7, you diminish your decision-making capacity by 10%. So it's kind of interesting. We start thinking back at meetings, and those meetings have 30 people or 20 people, and you think about smaller groups and the outcome of those meetings, you start to realize that really is that probably really is true. We always try to keep meetings really small unless it's we're just dispersing information, which then obviously you can have large groups, but those large groups aren't decision-making groups. They're just dispersing of information. And so this is what a innovation team looks like. You got tons of sticky notes everywhere. Everyone's like slapping 5s. You can see, everyone's working together. No one's on their laptops. Notice this. If you ever get them like opening up laptops, you're just totally finished. That's not, that just means that they're not engaged anymore. Next. And so this is one of my favorite artists. Banksy is a street artist. Now he sells his paintings for like millions of dollars. I don't know if you've ever seen his work, but it's kind of brings us to creativity. This street artist started selling paintings, and his last one sold for $1.4 million at Sotheby's. And after the hammer dropped, the art shredded itself in its frame, and now the piece is even worth more. Shredded. So that's really, to me, that was creativity. I was really inspired by that. Next. So I really think that, some people say I'm not creative or I'm not artistic. I can't draw. I think that all people have ideas. Everyone has ideas that are useful. I think that many times, either educational system or at home, we're told that we're not that type of person, but if you tap into this resource, all people have very good ideas. And it's really the most satisfying part of my job is listening to people's ideas, but it can be difficult to coax ideas out of people. We have a family friend that's a COO of an energy company, and he I asked him, I said, how do you guys do innovation there with such a large company? And he said, the best way to get good ideas is just go to your frontline staff, just wander around and talk to people. He said the frontline staff has the best ideas in the whole company. So it's really important. Norman Bodek, this guy was famous for bringing the lean methodology from Japan to the US, and one of the most critical findings he found was that the Japanese companies knew how to unlock this creative potential of the workers, and so frontline staff, and that's what he wrote. That's like his most important finding in all of this, is that these secrets were contained in those frontline workers. Next. So I don't know if you guys recognize this, but the old space shuttle used to have a white like fuel tank, and then the next generation one had a red one. I didn't understand why it looked like. Why is it all rusted? It looks terrible. They should put some paint on it. Well, it turns out in the 1980s, NASA came to Lockheed Martin and said, hey, we need to cut a lot of weight off of this shuttle because it's too heavy to launch the stuff we want to launch. And so, in typical fashion, Lockheed engineers went in with all of their top engineers, started using titanium, rebuilt everything, and they still came up 800 pounds short. And they were like, what are we going to do? They talked to happened to have a painter nearby, and he said, hey, you know what? It takes 200 gallons of paint to paint that tank. And he said, each one of those gallons weighs about 4 pounds. He said, if I don't paint that tank, you probably save your 800 pounds right there. And that's what they did. They stopped painting the tank, and that's how they saved the weight. So really good ideas from frontline staff sometimes. Next. So this is one of those Google workspaces. Just wanted to talk about workspaces because, when people think about Google, this is one of the most famous sort of things you think about, is the AstroTurf and the plants, and it looks amazing. I'd love to work here. But I mean, what is the real value in this situation? I mean, obviously you attract younger talent, maybe better talent, but this is really not a new idea. Next. You see that these shared workspaces were developed. These are Borghettas. These are 15th century Florence, Italy. They realized the potential of shared workspaces and the value that it created around that. And that's one of the things that they did. During the Renaissance, they would combine different, I should say, not only different types of workers, but workers that could make designs actionable. So there was a lot of different kinds of workers, but for instance, an engineer would come up with a concept and would be seated next to an artist, and the artist would draw the rendition, and then next to that person would be a blacksmith, and the blacksmith could actually create the component. I can only imagine the other types of individuals that would sit in these pods, but it was actually focusing their efforts towards one another. So all of the components were there. And I know a lot of universities now have come up with these innovation areas where they invite computer programmers and electrical engineers and physicists and scientists and all these different people together in this main working area. So this is how they innovated during the Renaissance. But the AstroTurf is really cool too. Next slide. So you can see even Google during the pandemic, they stopped working at home, or they stopped working in groups and they started working from home, but they're still innovating. So you kind of wonder, how valuable are these spaces? Anything more than just bringing people together, the right people together to start talking about things, these diverse groups, seems like that's the secret. And as all of us work from home, even on this conference, we're still collaborating together. We're still sharing ideas, and eventually even the Google employees were sent home. Next. And I hate to keep going back to World War II, but just this idea is very timeless of this sort of innovation. And I mean, even during World War II, there was a shortage of rubber, of natural rubber, and that's because the Japanese had taken over both the Dutch East Indies and Malaysia, and that was the world supply of rubber. And so the government had to act fast, and so they went out to companies like Firestone, Goodyear, Goodrich, and they said, hey, we need a we need a synthetic rubber. You guys got to put your patents and scientific information aside. You guys got to work together. And by 1944, they'd come up with the chemical formula for synthetic rubber. And by the end of the war, they were making 800,000 tons of synthetic rubber a year. And you can see how that really rolled into the modern era, because we never would have been able to achieve, you know, the amount of material that is needed for our modern era now if we hadn't have done that back in the past, if everyone had squandered all their technology. So you can innovate even when you are spatially separated, and even if you have different companies and different interests, innovation can still happen. It's just sometimes you have to have a war to do that, though. Next slide. And so human intelligence, let's just talk about that. You know, no one really cared much about creativity until these 20-somethings started selling internet startups for hundreds of millions of dollars. But really, I mean, our human intelligence is all about creativity. And, you know, it kind of frustrates me sometimes because we traditionally measure human intelligence largely on our ability to memorize and regurgitate facts. But these things are already known to be true in other places. And human intelligence was really developed, if you start to look at it, it was really developed to allow us to adapt to new situations, new problems, new places. It was really the creative part of our intelligence that really allowed us to be so successful as an organism. And as a result, people have been able to populate almost every climate on Earth, even this place in Peru that's home to 50,000 people. It's over 16,000 feet. I mean, people always talk about the 14ers in Colorado, but 16,000 feet, these people are living there with electricity. They probably have schools. They have a whole city there. I think there's a mine or something up here, or some sort of resource that draws them up here. But it was really adaptability and that sort of creative intelligence that allowed us to populate such rugged climates and with comfort, with electricity. Next. And so when you start thinking about that, we have these algorithms for almost every area of healthcare now has an algorithm, and it has a standard of care. Everything from anticoagulation schemes, which is what this is, to the diagnosis of endocrine problems, treatment of urinary tract infections, treatment of lung infections. All of this is algorithmic. You can look in any journal and see that. But the EHRs really have the information. In many cases, EHRs also know the algorithm, and they will pop up. They'll give you pop-ups when you do things wrong. And so as providers, we're kind of in this position where we read the EHR to aggregate the data we need. We memorize the algorithms, and then we do the best to put the two together. And then we get it wrong, the EHR tells us about it. So at the end of the day, the EHRs, I feel like the EHR is really just kind of testing our abilities for reading comprehension and memorization. And it's, you know, so, I mean, I think in the future, soon in the future, computers will offer up treatment plans based on the data, and providers will really just be editors, and they'll look at the information and they'll discern whether it's correct or incorrect, whether it needs adjustment, and it'll free up providers really to use their brain to interact with the patients and solve new difficult problems that computers really struggle with. And these creative intelligence skills are the real human value add, I think, to patient care. Next. When you look at the human brain versus the computer, it's really amazing. You see the Chinese supercomputer has 34 quadrillion CPS. Human brain is at 10 quadrillion CPS. Computer takes up 720 square meters, and our brain only takes up about 0.2 square meters. This computer uses 24 megawatts of power, and we only run on about 20 watts, the equivalent. Next. And so, but when you start looking at the advantages, the computer, you know, obviously has faster memory, it's more precise, greater storage capacity, won't fatigue, 24/7, you know, operation. But it only has about 2 to 3 connections per transistor, and the transistors are in serial chains. The difference in the brain is it's really good at learning and adapting, and the neurons are connected in parallel in a neural network, but there's about 10,000 connections per neuron, and that's really the difference. That 10,000 connections per neuron. Next. If you look at the microscopic view of this all, you can see that the neurons on the right, you can see how complex that architecture is compared to the computer chip on the left, which is very good at looking at the objective world, mathematical calculations. It's fast, it's accurate, it's dependable, but the image on the right is more about solving complex problems, adapting to new situations and being creative. And I think this was very evident when we got the IBM Watson, right? In the I don't know how many of you are familiar with the Toronto moment, but basically this computer did extremely well in Jeopardy because a lot of it's memory based, but it made this tremendous mistake called the Toronto moment, where it was asked what American city largest airport is named for a World War II hero. And what it came up with the answer was Toronto, which of course is wildly wrong because it's not a US city. And, how did it come up with this answer? Well, when computers get things wrong, they get things spectacularly wrong. And you notice this most with voice transcription errors. When you type something and you get it wrong, you misspell it by maybe 1 or 2 characters. When the computer gets it wrong, it's comical. It's a complete sentence, and spell check doesn't pick it up either sometimes. So next. And so this is the way the computer, we're training them to objectify the analog world around us. This is the Tesla vision. You're all familiar with that. Classifying objects in the environment and trying to make sense of them, because that's the only way really computers can process information, is to kind of objectify it. It's a 0 or it's a 1. Next. And even in sports, we're using this to detect and classify objects in sports. How fast are their movements? Moneyball, you're all familiar with. May not be as familiar with the book Actionable by Ben Ryder. Similar sort of thing. Everyone's doing it now. It's data-driven baseball. And if you're not doing data-driven baseball, you're probably not competitive. But many teams have won on this strategy. And so they're using this not to only assess in-game performance, but also to assess talent, rising up through the ranks and make decisions about that. Next. And then objectively assessing objects from radiology images. This is a huge topic right now. One of my colleagues, Dr. Garg from MD Anderson's working on this, and he's made tremendous strides. I'm very impressed with some of the stuff that these artificial intelligence engines can do. But there is a lot of monotonous work in radiology, and that's probably where computers fit the best, is in that monotonous work that's just very fast and non-fatiguing type of work. Next. And so with all of this new technology, there's always this temptation to develop this new technology and find people that want to use it. But that's really the backwards way that we should be working through this. And it can be very difficult to get change the mindset of people, especially when you have, a lot of really cool technology. Next. So the way it should work is, you understand the users first, you develop these concepts, and then develop technology really to apply these concepts and to solve a problem. One of the things that I think is really cool is Nuance has this thing called ambient clinical intelligence. I don't know how well it works, but it listens to the conversation between yourself and a patient, and it builds a note for you and builds orders and things like that. And it's a phenomenal concept, and I think it's definitely the future. Yeah, hats off to those guys. Next slide. Many of you probably have been doing design thinking for a while, but maybe you didn't know about it. Design thinking was really this catchphrase was created by Tim Brown, and he's a CEO of IDEO. He is, he's kind of formalized the structure of some of the things we've been doing for a long time. But I think this is absolutely, this process is transformational, not only to innovation teams, but I also use it for A lot of meetings, just regular meetings. It's pretty easy to dive into, but you have to kind of guide people a little bit. There has to be a process around finding solutions to problems, and I find that this one is very, very forgiving, and it's extremely useful in almost any situation. Next. So the process really is you have to empathize with the customer. And remember, we talked about deep empathy. It's not just empathize from a distance. It's you go into the clinical room, you see where the patient's being taken care of. You know, these are all medical staff, but you'd have like maybe a couple of, you know, IT people, you'd have financial people, or, you know, you'd have a small group. It might just be you. I used to take our CFO around on these ward rounds, and it was just, he loved it. He loved it because it really gave him insight as to how does the care really be, how is it really delivered, and you know, what does it look like? But this insight is extremely important. The next step, and this is where you really got to tell people to be creative, you really got to encourage them to come up with wild ideas, is well, the next step is you got to come up with a problem. So problem statement has to be phrased in form of a verb. So as a former ER doctor, you many times ask a patient, what can I help you with? And they say, well, I need a CT scan. And you say, well, that's fine. You know, if it was just that easy, I could just order a CT. I'd love it. But, you know, what are your symptoms? And so then you have to kind of engage them in that conversation to tell you really what's bothering them. It's the same way with providers or any group. You ask them, how can I help? And they say, well, I need this software program. And you say, well, back off, hang on one second. What is really the problem? What are you trying to really solve? Sometimes it's a really simple solution, and you really have to back off a little bit. So I always like to form it in the phrase of verb. So I need to be able to find patients that are at risk of stroke, or I need to be able to contact people that are at risk of stroke, or I need, you know, not I need a phone or I need a computer. So that exercise is really useful. And then you generate ideas off of that. Those ideas are typically those ones you see on the little sticky notes. You paste them up all over a wall. Everyone's encouraged to be, you know, crazy and to come up with just any kind of idea you can. And that's where you really stretch people. And then as you start to look at the ideas, you don't eliminate ridiculous ideas. What you do is you determine what a cost is for each idea. So one of the exercises that they typically will do in industry is not say, well, your idea is wrong or your idea is not doable, but what would have to be true for that idea to be for us to follow that? Or how much would it cost for us to follow it? What would we have to do in order to make that possible? And so once you quantify the cost in that way, then you're able to compare all of those items line by line. And then once you compare all of the costs, you establish which one's the best choice, and then you pilot that idea, and you pilot it early and often. So this is where you can't be afraid of failure. You got to like try it in a small group, pilot it. If it doesn't work, be honest about it. Come back. What was wrong? What's another option? Is there some way we can modify it? And doing that in rapid development cycles is extremely effective way of solving problems. And it's not always the most sophisticated way solution to a problem. It many times is a very easy solution to a problem. We've had solutions to problems that have been as simple as giving the patient a clipboard while they're in the waiting room. We've had some that are most sophisticated as let's use machine learning to determine if this person will be alive in 30 days. So that, you know, it could be any one of those solutions. Next. And so this is what it looks like. You know, it just starts out as a messy, big mess. And then as you move through it, it starts to become more of a refined concept in a design. I often think about it as bone remodeling. The osteoblast and the osteoclast start to, you know, fight together, and they come up with what the right structure is based upon the tension on the bone. And you come up with a really brilliant design that's very functional. Next. And we talked about the group size too. you know, large institutional groups, not very effective for this kind of stuff. Small, diverse group, very effective. And next. And these are just lists of companies that use this sort of design thinking approach to compete against one another. I mean, obviously the huge, you know, big companies see value in this. And, you know, the next, the value that they came up with this thing, design value index. This is not a stock index or anything like this, but it was just something they conceptualized, and they saw that these companies that use this design value as part of their operational process showed like way more value gains than even the S&P 500, which is kind of the gold standard. And so that I don't think this is around anymore, but it just kind of a perception. Next. And that's all I really have. I'll take your questions and any comments.
Thank you, Dr. Henderson. That was very interesting. I really liked the process of thinking through, asking, you know, the question with a verb, and you know, I think that, you know, we get asked, can you create a dashboard for this, or can you do that, and not always a lot of thinking through what it is they're trying to solve. So I really appreciate that, and I think it's something that a lot of people could use in many different ways. At this time, do we have any questions for Dr. Henderson? We're getting a lot of compliments. Thank you, really enjoyed the presentation. It was great. I don't see any questions, but a lot of compliments at this time, Dr. Henderson. So I appreciate, you know, being able to be stretched a little bit in how we think about things, and not so narrow-minded sometimes. So if we don't have any other questions, we will be wrapping up for the day.
Thank you.
Thank you. So thank you everyone for attending. Tomorrow will be the last session, session 3, and you will use the same registration that you used today to get in. I've been sending it out as a reminder because we have a few people that are only attending certain sessions, and we appreciate everyone's participation. And I'm still getting compliments, Dr. Henderson, on your presentation. So I think we heard a lot of great things today, and hopefully everyone enjoyed it. Don't forget to go look at the posters, and we will see everyone tomorrow. Thank you.